Have you ever heard that orgasms can happen without direct genital touch and wondered if that is really possible? Lips, mouth, nipples, the anus and prostate, even during childbirth, people have reported climax from all of these contexts. I am Dr. Fiona Gray, a relationship psychologist and sex educator. Today, I will walk you through what researchers and clinicians have observed about non-genital pathways to orgasm, why the brain plays a starring role, and how sensitivity, hormones, nerves, and context all come together. This is educational, respectful, and meant to help you understand your body with less mystery and more care. Many people describe orgasm as a brief, altered state of consciousness followed by deep relaxation. It is not surprising that some cultures nicknamed it the little sleep. Brain imaging shows that during climax, networks involved in sensation, reward, attention, and motor control shift together in a coordinated wave. Interestingly, some of these brain changes overlap with the patterns seen in certain seizure types, not because orgasm is a seizure, but because intense synchronized activation can look similar on scans. Let us start with erogenous zones in general. An erogenous zone is simply a body area that is especially responsive to stimulation. Although genitals are the most reliable route for most people, some report orgasm from sustained attention to other areas. In one report of over 200 adults, a meaningful minority said they climaxed after stimulation of places like the neck, inner thighs, or groin lines, or even fingers being kissed or sucked. The mechanism is not magic. It is the combination of nerve endings in the skin, the meaning and anticipation attached to the touch, and the way the brain integrates those signals into arousal. The mouth is a powerful example. Infants self-soothe by sucking because lips, tongue, palate, and throat are densely innervated and calming. In adults, focused oral stimulation can be intensely arousing for some. That is one reason many people find giving or receiving oral sex highly erotic. The voice, breath, and closeness added to oral touch can further heighten sensation through expectation and intimacy. Nipples are another well-documented pathway. For many women and some men, sustained nipple stimulation can trigger orgasm. Two things help explain this. First, nipple touch increases oxytocin, a hormone that rises during climax and can stay elevated briefly afterward. Second, brain mapping studies suggest that nipple stimulation activates cortical regions that overlap with those activated by clitoral and vaginal stimulation. In other words, the brain can interpret persistent nipple input as part of the same arousal network that culminates in orgasm. The anus, and in men the prostate through the rectal wall, can also be pleasurable and occasionally orgasmic for some. The pelvic nerve carries signals from the anus, rectum, vagina, and cervix to the spinal cord, which helps explain why rectal stimulation can feed into the same arousal circuitry. When someone enjoys anal play, combining it with penile, clitoral, or other external touch can intensify the overall experience because multiple nerve pathways are engaged at once. As always, preparation, hygiene, plenty of lubrication, and consent are non-negotiable for comfort and safety. You may have heard stories of orgasms during childbirth. While uncommon, reports exist. A small percentage of women describe orgasmic feelings during labor. Possible reasons include pressure and stretching along the front vaginal wall, where many perceive G-spot sensitivity, very high oxytocin levels during labor, and the way intense sensation and pain networks overlap with arousal networks in the brain for some individuals. None of this means labor should be erotic. It simply highlights that strong sensory input can converge on shared pathways in different ways for different people. Arousal and erection-like responses also occur during sleep without any deliberate stimulation. Many men experience nocturnal penile tumescence, and many women have clitoral tumescence during certain sleep phases. These events are driven by sleep architecture, hormones, and autonomic nervous system cycles, rather than by direct touch. They are part of normal physiology. People living with spinal cord injuries provide another window into the flexibility of arousal pathways. Depending on the level and completeness of injury, genital sensation may be reduced, yet areas just above the injury level can become highly sensitive. With the right kind of stimulation and context, some individuals report orgasm from touch to those new hot zones. It is a reminder that the brain is the final organ of sex, and that bodies often find alternate routes when the usual ones are blocked. There are also rare conditions that sit at the edge of this discussion. Persistent genital arousal disorder, for example, involves unwanted, untriggered arousal sensations that can be distressing and disruptive. If you or someone you love experiences symptoms like that, a clinician who specializes in sexual medicine can help evaluate and guide care. A few closing thoughts. None of the routes we have talked about today are rules or requirements. If non-genital orgasms are not your experience, nothing is wrong with you. If you are curious, approach your body with patience and consent, experiment slowly, and prioritize comfort and communication with your partner. If anything hurts, feels unsafe, or raises medical concerns, speak with a qualified professional. Take good care of yourself and your relationships. Your curiosity and well-being matter. If this was helpful, subscribe for more calm, science-based guidance on intimacy and sexual health, and share a question you would like me to cover next.